Welcome, everybody. Let me talk about my PhD projects on hemodynamic management in the perioperative period of non-cardiac surgeries. I would like to start with a quick summary of the findings of my first project. Many patients undergoing major non-cardiac surgeries are chronically treated with renin-angiotensin system inhibitors due to hypertension or chronic heart failure. And these drugs can cause adverse events perioperatively, therefore understanding to continue or discontinue them in this period has high importance. Our systematic review and meta-analysis showed a significantly higher incidence of intraoperative episodes of hypotension in patients who continued these medications. Therefore, routine continuation of these drugs should be stopped. And further research is needed to identify subgroups that could benefit from continuation. And this data should be implemented into current management guidelines. Let me introduce myself. I'm Zsuzsanna Weber. I'm a PhD student and also a resident at Semmelweis University, Department of Anesthesiology and Intensive Therapy. My vision is standardized yet personalized patient care worldwide. My mission is to help create high-quality evidence-based strategies while being effective in patient care. I have two projects. The first one is about continuing or discontinuing renin-angiotensin system inhibitors, and the second is about multimodal individual hemodynamic management. Let me start with the first project. The problem, again, is that many patients undergoing major non-cardiac surgeries have hypertension or chronic heart failure, and antihypertensives like angiotensin-converting enzyme inhibitors and angiotensin receptor blockers play a key role in the treatment of these conditions. And because general anesthetics also have blood pressure lowering effect, we know that continuation of these drugs can lead to hypertension and cause deadly complications. On the other hand, discontinuation of these drugs can lead to hypertension, and it is uncertain whether withholding them actually reduces hypertension-associated complications. The guidelines in the topic are controversial. For example, Japanese guidelines suggest withholding on the day of surgery. Canadian guidelines suggest withholding a day before surgery, and ESC guideline has different recommendations for patients with or without heart failure. Also, you can see that the class of recommendation and level of evidence is quite low. So in order to improve recommendations, we chose to investigate whether continuation strategy is superior. The clinical question is if continuation of RASes is the superior strategy in reducing postoperative complications. We included adult patients undergoing major non-cardiac surgeries who are chronically treated with RASes, and we compared continuation to discontinuation. The primary outcome is mortality, and we have multiple secondary outcomes. And the hypotheses were that continuation strategy is the superior. We used this search key, consisted of 3 domains, and following the Prisma flowchart, we ended up with 18 eligible articles. And let me show you some results. 30-day mortality is our primary outcome, and this forest plot visualizes the differences between the two graphs. And we included both RCTs and observational studies into this analysis with altogether roughly 50,000 patients. We faced a high heterogeneity, even though the I-square test couldn't detect it. And the overall effect is expressed as odds ratios. It's 0.91 in favor of discontinuation. You can see that the diamond crosses the zero effect line, and the confidence interval includes 1, meaning that this is not a statistically significant result, although it can be clinically relevant, but further research is necessary. This forest plot visualizes the difference in intraoperative episodes of hypertension between the two groups. And this is one of our most important outcomes, because it's been proven that every time when the mean arterial pressure drops below 65 millimeters of mercury, the risk of adverse events increases regardless of the duration. So this is why it's a very important outcome. We only included RCTs into this analysis with roughly 10,000 patients, again with a high heterogeneity. and the result is expressed as risk ratios. It's 1.33, and you can see that the diamond doesn't cross the zero effect line here, and the confidence interval doesn't include 1, so it's statistically significant and clinically relevant. Here is a quick summary of the hard endpoints. There were no statistically significant difference in these outcomes. The strength of our study is that this is the most comprehensive. We screened the biggest amount of studies during the systematic search. We have the broadest set of outcomes, and we use the most robust methodology, meaning that this is the only meta-analysis that uses grade assessment, and the only meta-analysis that assesses risk of bias for each outcomes, not only each articles. But on the other hand, we have limitations. 2 meta-analyses were published in the past 1 year in this topic, and we faced a high heterogeneity, and we included not only RCTs but observational studies too. All parts of the manuscript has been written. We are polishing and doing the citation. I would like to submit it by the 10th of September. Let me move on to the second project about multimodal individual hemodynamic management. The problem is, even though anesthesia is safe, high-risk surgeries are still associated with postoperative complications, and only 10% of the surgical populations are at high risk, but that 10% is responsible for over 80% of the overall mortality. We know that intraoperative hypoperfusion increases the risk of postoperative complications. Therefore, adequate hemodynamic monitoring is crucial. The routine monitoring that we use for a standard risk surgery includes heart rate measurement, ECG, non-invasive blood pressure monitoring, and pulse oximetry. And this can be supplemented with central venous pressure measurement, etc. in case of high-risk surgeries. This is what we call advanced hemodynamic monitoring. Excuse me. In case of multimodal hemodynamic monitoring, we would get even more detailed information, for example, cardiac output, stroke volume, etc. And if we put these parameters in the context of the given patient, given time, we could do personalized care. The whole purpose of the hemodynamic management is to keep balance between oxygen delivery and oxygen consumption by avoiding hypoperfusion. And in case of individualized care, it means that we have to put all these parameters in the context of the given patient, given time, which is supported by strong pathophysiological rationale, but clinical evidence is lacking. And given that it's a very complex and time-consuming method, its efficacy and safety cannot be guaranteed based on only pathophysiological rationale. In order to find out whether we need this very promising but also very slippery method, we need to perform a randomized controlled trial, for which the clinical question is if this multimodal strategy is superior to current standard of care in reducing postoperative complications. We would include high-risk adult patients undergoing elective major abdominal surgery, and we would compare this multimodal strategy to conventional care, and the outcome would be a composite outcome of postoperative complications. Our hypothesis is that multimodal individual hemodynamic management is superior to current standard of care. The second project is on hold until the first project is done. So in summary, I would like to finish the first project in the September of 2025, and the second by February 2026. Let me finish with a quote from Erykah Badu. "The man that knows something knows that he knows nothing at all." So let's not settle for what we believe to know, but keep on discovering and learning. Thank you. I'm sorry, but my voice is gone, so I cannot take any questions.
Thank you. Thank you for the great presentation. Still, you are obliged to take questions if they are presented. So are there any questions from the audience? Yes, please.
Thank you for your presentation. Sorry to bother you with questions, but I'm really curious. First of all, patients undergoing chronic treatment with antihypertensives might be or may be more responsive, so to say more sensible, to certain stages during the anesthesia procedure. Have you got any proof that those RCTs have accounted for this fact? I'm thinking of medication dosage, for example.
I think it's not about the RCTs, but it's in the daily practice that, yes, we know that the induction dose of propofol is your body weight 2 times, but it can be very different from that if you have multiple comorbidities, especially hypertension. So you have to individualize the induction. Yes, it was this the question?
Yes, so, yeah. So you have proof that in those studies, frailty, comorbidities was taken into account?
I think so, yes.
Okay, thank you.
I would like to ask a question. You mentioned heterogeneity. Would that stem from like the difference between ACE inhibitors, discontinuing or continuing, or angiotensin receptor blockers, maybe?
It's in the ASHA score. So for those who are not familiar, it's a risk stratification score. Comorbidities in how many drugs the patients take. So the heterogeneity is inside of the studies too, and also between the studies, because there are studies that include all kinds of surgeries. Acute surgeries too. There are studies that only include vascular surgeries. The timing of the discontinuation was different. There were RCTs that took the pharmacokinetics into consideration and timed the discontinuation according to that. So, yeah, these factors.
I see. And sometimes angiotensin receptor blockers are not the strongest antihypertensive agents. For example, they are very frequently applied together with calcium channel blockers.
Yes,
so were
exactly.
they also withheld if the ACE inhibitor was discontinued?
What was the question, sorry?
Like many hypertensive patients will get calcium channel blockers as
exactly.
well as ACE inhibitors.
Exactly.
So would these studies also include people who had combination therapy and everything was dropped, not just the ACE inhibitor?
Yes, this is my problem with the whole study and with all the RCTs, that most of the patients are on diuretics too and on calcium channel blockers too. So at this point, our suggestion to further research and policymakers was to find subgroups and etc. But in my opinion, we should maybe change the anesthesia, not the patient. So like induce with ketamine and propofol combination or something like that. But I'm too small for that. So
thank you for your adding your opinion. If there are no, yes.
Since you answered so nicely, I also dare to ask a question, which is short. You mentioned that there were 2 previous meta-analyses. So
yes.
Are your results the same as those, or are they different?
Mostly. So one of the meta-analyses, which was published during the winter, they also included observational studies and RCTs too, but not all the studies that we included. So they were missing some, and also they included a study that which is patients were ambulatory surgery patients, and they calculated mortality like from 3 papers, and one of them was ambulatory surgery. So it's and also they didn't use an RCT which has a post-hoc analysis on acute kidney injury, and they found a significant difference in acute kidney injury without that paper, but we, with that paper, found no significance. And the other meta-analysis, they only used RCTs, and yeah, their findings were aligned with ours.